So at that time, did they address the swelling?
Yes, ma'am. Surgery was done,
Yes,
but
ma'am. They did just the resection, but she did not receive any form of neoadjuvant or adjuvant treatment.
Okay. And after surgery, how much time was the disease-free interval?
2 years, ma'am.
2 years. Okay. Okay. It started growing back after 2 years.
Yes, ma'am.
Okay. Fine. So, in your demographic history, what is important in this lady is a young lady. Okay. So, okay. So it was recurrent swelling. Okay, with post excision history of excision biopsy at the same site. So, what is the most what is your differential diagnosis at the end of your history, ma'am?
Ma'am, it is swelling on the inner aspect of left thigh, probably malignant in nature, ma'am.
recurrent swelling.
It's a recurrent swelling that is most important. Okay, whenever in soft tissue or bone sarcomas, any past history of similar swelling and recurrence at the same site or nearby site is very important. Okay, so it will change the management to a greater extent. Okay, that is important. And you think it is of malignant etiology because it has recurred, right?
Yes, ma'am.
So you think it is soft tissue or it is bone? Origin is from soft tissue or bone?
Ma'am, it can be both, but since the swelling has come first and the pain has not come with it, and it was not painful the first time also, it's probably from soft tissue.
Yeah, probably from soft tissue. That's how you should answer. Okay. So most likely in a case of a bony swelling, pain comes first and swelling comes next. Okay. In a soft tissue, swelling comes first, pain comes next. Okay. So, taking it to be a soft tissue tumor. Okay. Anything else which you can think of?
Ma'am, it can be a benign aggressive or a locally advanced kind of tumor also.
So it can be either a sarcoma or it can be any benign tumor. Okay, like a what are the most common site of the tumors there where your swelling is there? Last time we discussed the site, no? So,
ma'am, mostly most of the tumors they occur in the most common soft tissue tumors occur in the truncal extremities. In the truncal extremities also, most of them occur in the thigh and that too in the anterior compartment.
Most common, your statement is confusing. Most common occur in the trunk or it is in the extremities?
Extremity, ma'am, sorry. Most common
occur in the extremity.
Yes.
How much percentage?
46, ma'am, I think 46 to 50%.
Around 45%. How
Yes,
much occur in the trunk?
I think 15%, ma'am.
Yeah, generally, see, 60% occur in the extremities. Among that, lower limb will be 45. Okay.
Yes,
upper limb, upper extremity will be around 15% or
yes,
60%. Okay. Yes, and in the trunk, it will be around 15 to 20%.
Yes.
Okay. So, in retroperitoneum,
15%. Yes, ma'am.
Yeah, 15%. And head and neck will be
10%.
Yeah, 8 to 10%. Okay. So, how do this how does the presentation of a retroperitoneum? We'll just brush up simultaneously RPS also. We may not get time now. So we have scheduled till Thursday. So that's why I'll cover a part of RPS also. Okay. So how do RPS tumors differ from STS in extremity?
Ma'am, in terms of history, in terms of staging both of them, in terms of history, the extremity swellings, because they are visible, they appear, they are they are addressed first. They're symptomatic first. Retroperitoneal swelling is often present with vague symptoms or compressive symptoms, and they are addressed later. In terms of staging, if there is a
So which are bad? RPS is bad or extremity sarcomas are bad?
I think extremity sarcomas.
Because it is detected late, I think so.
RPS is bad. Okay. So, and what is difference in terms of imaging? What is the imaging of choice for extremity sarcomas, and what is imaging of choice for RPS?
For extremity sarcoma, it is MRI, ma'am, and for RPS, it is CT scan.
Why so?
Ma'am, because of better soft tissue delineation, because most of the times that we do MR, we have to look at its relationship with the other soft tissue and the neurovascular structures. So MRI is a better modality.
In RPS also, that's not the difference. Anyone?
Ma'am, bowel will produce motion artifact if we do.
That is the thing. Okay. In abdominal, this one, MRI, it will have motion artifacts. Okay. So that's why CT is the diagnosis of choice. But you can still do an MRI when you are in doubt about the neurovascular bundle or any vital structures. Okay. But CT itself is sufficient in RPS. Okay. Unlike extremity soft tissue sarcomas. Okay. So yeah. Then so it started. So do you like to see something specific in this case since it was already excised? So what's your concern here?
Ma'am, I want to make sure that if I get an access to the previous histopathology, was it kind of what sort of an excision it was? What sort of margins did they have?
Okay. You'll also look at the scar. Okay.
Yes, ma'am. Yes.
So it's important, no? Limb salvage surgeries and all. So whenever, okay, at your history level, you still don't know if there's a bone tumor or soft tissue tumor. Okay. So, but still contemplate and plan for a limb salvage surgery, you need to know where exactly incision was put. Okay. So improperly placed incisions are one of the contraindications for limb salvage. Correct. So then, what about you missed something in the history? Since we have discussed last time in bone tumor, I'm not going into metastasis and all. But next page.
History of radiation was not used. History of radiation, history of any associated swelling.
No, she told that there was no radiation given, but no history of exposure to radiation is okay.
No
1 point.
Radiation, any additional, no additional swelling from the groin area, just to rule out.
Okay, regional lymphadenopathy. Anything else pertaining to limb? You know it is soft tissue, but at the level of your history, you should know whether the distal limb there is any edema or not.
Any altered
or there is any atrophy.
Altered sensation.
Okay. So there are any neurovascular compromise. So that history is missing. Important, no?
Yes, ma'am.
Yeah, and also, as I said, you cannot, you should ask for both for bony symptoms and the soft tissue symptoms. So you should also ask for any restriction of movement. Okay. So you told that there is difficulty in walking. Okay.
Sitting.
At the joint above and joint below, is there any restriction of movement? So
Yes.
at the level of your history, think broad. You still don't know it is soft tissue or bone. Okay.
Yes.
So these 2 points are missing in your history. Now you tell me what are the soft tissue tumors which spread by lymph nodes?
Ma'am, these are alveolar these are synovial sarcoma, alveolar rhabdomyosarcoma, malignant fibrous histiocytoma, and clear cell sarcoma, synovial sarcoma.
What is it?
Sorry, no?
It is fair or masses? The
Yeah,
quotes are like mnemonic is that one, no? Masses. Yeah, tell.
Malignant fiber histiocytoma, angiosarcoma, rhabdomyosarcoma, clear cell, epithelioid, and synovial, ma'am.
Epithelioid is what you didn't tell. Okay. So yeah. So now you tell me, what are the soft tissue sarcomas which spread to spine? What are the soft tissue sarcomas which present with brain mets? Okay. What are the soft tissue sarcomas which present with liver mets? My question is clear?
Yes, ma'am.
Yeah.
Ewing sarcoma and osteosarcoma lung mets.
Sorry?
Spine में alveolar soft tissue sarcoma. Spine.
Okay.
And brain met angio and alveolar sarcoma and spine liposarcoma undifferentiated.
Spine mein, what did you tell?
Undifferentiated lipo or something I am remembering. Maybe I am not wrong.
Myxoid or round cell liposarcoma. Okay. And what about bone mets, which are more common to present with bone met? Again, round cell sarcomas. Okay. Myxoid liposarcomas are more common to present with bone mets. Angiosarcoma, alveolar soft part sarcoma are more common to present with brain mets. Okay. So these are the most common sarcomas which we should know, spread by what route. Okay. Okay. Node we discussed. And yeah, next, what else you missed in your history? Go to the past history. So, if there is any occupational exposure, what will it be in soft tissue sarcomas?
Ma'am, it can be vinyl exposure or thorotrust exposure.
Okay.
Uh,
Anything else?
Low dose radiation if the patient is receiving of some kind.
Okay. What are radiation induced sarcomas, you know?
Ma'am, these are mostly angiosarcomas. These
Okay.
are often seen in patients who've received radiation for, like, in cases who had breast
CBS.
cancer and they have received radiation.
So,
these-
what is Stewart-Reeves syndrome?
It's, ma'am, sarcoma of the upper of the chest wall and the upper limb. Sarcoma developed in the chest wall and the upper limb.
So, is it due to radiation or is it due to lymphedema?
It is due to lymphedema, ma'am. It is not due to radiation.
Okay. So, can you tell me few? Okay, we'll go to the grade and all. Fine. Did you tell anything personal family history?
She had no significant family history, ma'am.
So, okay, what are the syndromes which are associated with family history of radiation? I mean, sorry. Yeah.
Leaf-Romany, retinoblastoma, NF1, neurofibromatosis type 1. Gardner syndrome is also there, ma'am.
Yes.
It's associated with desmoids.
Any FAP related things, APC related syndromes may be present then? Okay, just out of box question. Do you know any criteria for the Leaf-Romany syndrome? What's the name of the criteria?
Chompered criteria, ma'am.
Yeah, Chompered criteria. Right. So, if a soft tissue sarcoma occurs due to radiation, so what will be the period? I mean, the delay after
10 years,
radiation?
ma'am.
Yeah,
10
minimum
years.
of 10 years. And is it common in young or older individuals?
Ma'am, it's common in the older. It's common in the young, ma'am.
More common in young.
In the younger population, ma'am. Those the ones who have received radiation in the childhood period mostly.
Yeah. So, any other etiology of soft tissue sarcomas you are aware of?
Ma'am, any kind of lymphedema, any kind of foreign body, any kind of chronic irritation, most of them arise de novo, but some of them can be
Is
because
there
of
any viral etiology?
Kaposi sarcoma caused due to HIV, ma'am.
Anything else? Can HPV cause? Is it implicated in etiology of soft tissue sarcomas? It can. Okay. HPV, HIV. Okay, and ED. All these are. Okay.
Okay.
So yeah. So that's about etiology. Okay. So next one. Yeah. So soft tissue sarcomas have any relation to this smoking, alcohol?
Not that I'm aware of, ma'am.
So they don't have direct implication, but they can cause immunodeficiency, thereby leading to any viral infestation, and then leading to soft tissue sarcomas. Okay, next. Okay. Any soft tissue sarcomas that are specific to females, more common in females otherwise?
Desmoids, ma'am, they are mostly seen in Paris women who undergo cesarean.
Okay, fine. Next. And you can see in per se abdominal one, leiomyosarcomas, uterine leiomyosarcomas are more common. Okay.
Okay.
Then yeah, next. We'll go to the next. Examining. Yeah, 1 second. So now yeah, you take the slide forward. We are not going to discuss all this. Next. Okay, gait. So last time we discussed about gait, right?
Types.
Yes.
There, ma'am, that definition mila kya?
I told you, no, last time only.
No, you said
It's
कि
rhythmic
one.
contractions involving the lower limb, which helps in propulsion of the body forward.
मैं ढूंढा था तो मेरे को मिला नहीं था इसमें.
So yeah. So in inspection, did you see any scar? Yeah, until 30 centimeters below ASIS. How long was the scar?
Picture होगा.
Approximately 10 centimeters, ma'am.
So you are supposed to tell that, and extending in which compartment? Okay. So is it over the swelling? Is the swelling in and around it, or it's behind that scar? So that's all important. Okay. Okay. Now you see the swelling and describe. Okay.
Yes, ma'am. Ma'am, there is on examination of the on inspection of the limb, I can see approximately 15 into 10
Start
centimeters.
with the attitude of the limb. Okay.
Okay, ma'am. The limb is semi-flexed at the knee and and semi-flexed at the hip joint, and it's externally rotated, and there is few dilated veins over. There are few dilated veins at the distal end of the thigh. There is a scar visible. There is also a swelling visible. The swelling is approximately 15 into 10 centimeters into 5 centimeters, and there is the swelling appears to be bossylated in shape. It appears to be
surfaces look bossylated. Okay.
Surface looks bossylated. The shape of the swelling is globular. The surface appears bossylated. There is a scar overlying the swelling. The skin over the swelling appears to be stretched and hyperpigmented. There is also some hyperpigmentation over the distal part of the leg. There are no other scars or sinuses seen on the swelling.
What about the distal? Any it is wasting is there, or any
No
swelling
distal,
is there? Any
uh,
swellings in the groin?
no distal swellings, no distal scars, or no visible atrophy of the distal muscles. No inguinal swelling seen.
Okay. Now, anything else? Go back
Ma'am,
to your inspection stage.
it is approximately 5 centimeters above the knee joint and approximately 20 centimeters below the hip joint.
Yeah, you should tell approx surface marking of the swelling even in inspection. Okay,
Yes,
which
ma'am.
can be confirmed by
It is
palpation.
in a
Okay.
medial
Yes.
compartment, na? Then we have to say
Hmm.
from pubic
you-
tubercle.
Hmm.
Pubic tubercle and medial condyle.
So how many compartments are there in thigh?
Anterior, medial, and posterior compartment, ma'am.
Okay. So just go up one slide. Yeah. So what did you miss? Anything you missed? Okay.
Inguinal
Circumference,
crease
ma'am, I
और
missed, ma'am.
swelling को पहले crease बताना है, inguinal crease and knee joint.
Okay. I think more or less covered. Next, palpation.
Same बता दो ऐसे ही ना palpation finding.
Ma'am, on palpation, the temperature overlying the swelling was normal. There was no tenderness that could be felt. There was no on examination of the limb, the tone of the limb was normal. The range of
So
movement.
first sentence will be my findings on inspection regarding site, okay, size, shape, okay, are confirmed. Okay. That
Yes,
is
ma'am.
second. After local rise of temperature, tenderness, you are supposed to tell that sentence. Then you proceed. Okay.
Yes, ma'am. On examination of the limb, my findings of inspection were confirmed on palpation. There was no wasting of the distal muscles. The tone of the limb was normal. The range of movements at both the hip and the knee joint were normal. There
Avni,
was
first
yes,
the
ma'am.
swelling, Avni. Which plane is it the swelling?
Ma'am, the plane of the swelling is in the intramuscular. Should I describe the swelling first, ma'am?
First is always swelling, then the adjacent things. Okay.
Okay. There is a swelling which is approximately 15 into 10 centimeters in the medial aspect of the thigh, which is 5 centimeters from the tibial tuberosity and approximately 20 centimeters from
Inguinal ligament, what you said? Inguinal crease.
middle.
So what are you going to take as a bony reference point in this case?
Pubic tubercle.
Okay. Superiorly, what are you going to take?
Pubic tubercle,
So
ना?
here it will be pubic tubercle. Okay. But
ये
you can
obese
describe it as
patient
well
है
as
तो
from
मैम
A.
palpate होने में थोड़ी difficulty आएगी शायद pubic
Then you
tubercle.
can describe it from A side as well. Okay. I think in this patient, she can describe from pubic tubercle. Okay.
Okay.
Doesn't seem so like you may find it, I feel.
Okay, ma'am. So
Yeah.
it was approximately 20 centimeters from the pubic tubercle and approximately approximately 10 centimeters from the tibial tuberosity. Since the swelling was mobile the swelling was mobile but with restricted mobility in the direction perpendicular to the muscles, but was immobile in the direction of the muscle. On keeping the muscles in a taut position, the mobility was further restricted. The skin.
One second. I'm getting a call. 1 second.
a scar over the swelling, which was approximately 15 centimeters in size, and it seemed to have healed by primary intention, which was approximately 25 centimeters from the inguinal ligament. And the swelling was not compressible, and there were no palpable
बॉर्डर्स और
pulsations
एज और
over the
उसकी कंसिस्टेंसी, बस ये 3 चीजें जरूर बोल दे.
So always you should remember size, shape, consistency, mobility. Okay. These are things you should not. It should come as a flow. Okay. First you describe the swelling, then you describe the scar, then you describe the lymphadenopathy, then you describe the joint above, joint below, and distal limb. Then you also describe the neurovascular deficits. Okay, neurovascular, any muscular deficits, neurovascular deficits, all along with the swelling description. So if you have to tell it in a flow. That's why I'm telling every one of you, each one of you, that see, this is what happens when we read a PPT. We will not know, but when we present without seeing, no, so we will not be able to remember each point. So that's why I'm telling each one of you, practice without seeing PPTs. Okay. So now take 1 minute time. Okay. Describe it in one continuous flow. Okay.
Okay.
Yeah.
Ma'am,
Take your time. No problem.
yes.
Take half a minute. Just plan what you want to tell and then tell.
Yes, ma'am. Ma'am, on palpation, I confirmed my findings of inspection on palpation. There is on palpation, the temperature overlying the skin was normal. There was no tenderness over the swelling or over the limb. There was a 15 into 10 into 5 centimeter swelling at the distal aspect of the thigh, which was in the medial compartment of the thigh. It was globular in shape, with variegated consistency. The upper border of the swelling was approximately 20 centimeters from the ASIS, and the lower border of the swelling was approximately 5 centimeters from the tubal
20
tuberosity.
centimeters from ASIS, from a perpendicular line drawn from ASIS and medial to it. Is it not? Is it not? Is it below the ASIS? No, it's in the medial compartment.
Yes.
So when you tell the vertical, you should also tell the horizontal, how much far from the perpendicular drawn from ASIS. Okay.
Yes, ma'am. The consistency was variegated. The swelling was not compressible. On trying to move the swelling, it was having restricted mobility in a plane which was perpendicular to the muscles, underlying muscles, but it was having no mobility in the direction parallel to the muscles. On asking the patient to contract the muscle, the mobility was restricted further in the perpendicular direction. The skin over the swelling was not pinchable. There was no palpable inguinal lymphadenopathy.
Any fixity to bone?
No, ma'am, there was no fixity to the bone.
So, okay. So, anything else you want to tell? I told you just now,
Rounded edge or
neurovascular
smooth
deficit.
edge or consistency firm or variegated?
Consistency, I told.
Surface
Neurovascular
globular.
examination, distal limb, ma'am.
You have to tell neurovascular deficits. You have to tell joint above. So I'll describe. Okay. So you listen. So I'm not remembering all the dimensions, but I'll describe it in this one. Okay. So a swelling about 10 cross 15 centimeters is located in the lower 1/3 of the thigh in the medial compartment, about 15 centimeters below and 5 centimeters medial to ASIS. Okay, right ASIS. It's about 2 centimeters above the. This is in the thigh, right? So I can tell it is in the medial. It is about 2 centimeters above the medial femoral condyle. Okay, and it is its lateral border. its lateral border is about 10 centimeters in a perpendicular line drawn from the mid-inguinal point, and its medial border is diffuse. Okay, so it's a globular swelling with a uneven surface, looks bossylated on palpation, with an overlying scar which is about 5 centimeters in length. Okay, its consistency is firm. Okay? The skin over the swelling is not pinchable. On putting the underlying muscle into contraction, there is restricted mobility. So what muscle you will put, you have to tell. Okay, here it might be, what is the muscle?
It is adductor, ma'am.
Yeah, adductor longus or vastus compartment muscles. Okay, so on underlying, it's not fixed to bone. Okay, and there are no palpable pulsations over the swelling. There are no other swellings that are felt in the ipsilateral thigh or distal to the swelling in the leg. Okay, there is no wasting of the distal muscles. There are no obvious neurovascular deficits. The pulsations, the femoral pulsations, the popliteal pulsations, and dorsalis pedis pulsations in the ipsilateral limb are normal. Okay, there is the tone is 5/5, and there is the reflexes are intact. Okay, and there is no sensory deficits. Okay, the joint above, that is hip joint, and the joint below, that is the knee joint, are in the normal range of motion. There is no restriction of range of motion at the hip or knee joint. Okay,
Yes.
so there is no palpable lymphadenopathy, and the other side limb appears normal. There are no other visible swellings anywhere else in the body or in the abdomen. Okay, this will complete your full palpation. Okay,
Yes.
right?
Yes, ma'am.
Okay, now?
Yes, ma'am.
Right. Yeah, tone, power, all the sensory examination, reflexes, all are to be told. Okay,
Yes, ma'am.
and joint movements. Next.
I mean, thigh, what tendon reflex we have to see?
Knee reflex and
Knee reflexes have to be seen.
ओके वो
Ankle
सिटिंग पोजीशन
reflexes,
में जो सिटिंग पोजीशन में जो हम लोग टिबियल टिब्रोसिटी में मारते हैं
हाँ,
मैम
वही।
नी एंड एंकल दोनों देखना पड़ेगा ना लोअर लिम्ब में तो
Yeah, any lower limb, you see all the lower limb reflexes. Here, because your swelling is very close to the knee, so it is more important.
रिफ्लेक्स नहीं बोले तो मैम बोलेंगे, पूछने लगेंगे फिर।
नहीं बोलेंगे तो क्या हो? You have to tell. You have to know the grades of reflexes. Somebody like who is that? I forgot his name. From Tata comes, no? Then they are very particular about the examination of the swellings. Okay. Other systemic examination, I told you, na, most important is abdominal examination here. Okay. Abdomen, always with PV. Here it's a lady, so PVPR is very important. Okay.
yes ma'am.
So other system, lungs are very important. So what is the most common site of distant metastasis?
lung
Does it vary with the type of sarcoma, or it is same?
ma'am in the 5 tumors that we had read which we had discussed, it can also lead to regional lymphadenopathy, but otherwise most common site is lung.
For all, we just discussed, no, spine, liver,
Yeah.
brain.
Yes ma'am.
So they are also common. Okay, if they are, but it varies with the type of histology. Okay, so yeah. So what about yeah? Now how do you want to proceed? What is your diagnosis?
Ma'am, my patient 35-year-old lady with a swelling in the middle with a recurrent swelling in the middle aspect of thigh, probably soft tissue swelling, malignant in nature.
Okay. Anything else you want to characterize here? It is recurrent, ma. Okay.
I told ma'am
You are told, huh? Sorry. Fine. So, what do you want to do?
Ma'am,
Wait. There is some discussion before imaging. Okay.
yes.
Suppose it was not recurrent. Even though it is recurrent, it is 2 years later.
Yes.
So, do you want to do something?
Yes, ma'am. I want to do further investigations to confirm my diagnosis, to stage the disease, and to treat the patient.
Okay.
Yes,
To confirm your diagnosis, what would you like to do?
ma'am. I would like to do a core biopsy, but before doing core biopsy, I want to get an X-ray of the limb and then MRI of the limb.
So you want to do core biopsy, normally blind biopsies clinically or under image guidance?
Under image guidance, preferably, ma'am.
Okay, why?
Ma'am, because I want to take the biopsy from the most representative part of the lesion.
Solid
Okay,
part, I think
fine.
we should say. Solid
most
part we should
representative.
say, kya ma'am?
Representative part. Okay, and you should not go through the wrong track. So
Yes.
that is
Sorted.
under guidance.
Probably, ma'am.
And
Preferably, the surgeon who is supposed to operate the final should
Correct.
be the one who should be taking the biopsy.
okay, you told core biopsy. Suppose
Yes.
it's an incision biopsy. So what
Yes.
precautions you will take?
Ma'am, while doing an incision biopsy, first I would like to take 2 attempts to make sure that I have taken an adequate core biopsy. If still not able to get the adequate tissue, and if I have to go for an excision excision biopsy, I would like to do the procedure under GA. The incision should be taken. It should be preferably done by the same surgeon who's going to do the final surgery. I
Yes.
should take I should take the most closest approach to the tumor, preferably in the same line of the scar that my scar on the surgery is going to be, with minimum dissection, with minimum opening of the facial planes, and with an adequate incision biopsy that I should be taking, and preferably no drains should be put.
Even if put, it should be enclosed within the future area.
Surgical scar.
And there are 2 more points. No flap should be raised.
No
There should not
dissection
be any
should be done.
bleeding. Yeah, no
bleeding.
preferably not much bleeding. Yeah. So, and how many? Okay, this is one incisional biopsy. Okay. Can you do an excisional biopsy directly? What are the criteria for a direct excision biopsy in a soft tissue swelling?
Ma'am, in a very superficial tumor with less than 5 centimeter in size, we can attempt doing an excision biopsy.
Is it 5?
3 centimeter.
Yeah, it is 3 centimeter. Okay. Anything else?
In which prior incision biopsy has
So
been
it should be less than 3 centimeters. It should be like well defined. Okay. It means it should not be of high grade. Okay. It should not have any lymphadenopathy. Okay. It should be like that should be the final surgery you will be doing. Okay. Then only you can do that kind of excision biopsy. No post RT, no recurrent swelling should be included in that. Okay. So, fine. Any
Ma'am,
other biopsy?
Ma'am, role of FNA in recurrent. Can we do the in recurrent setting FNA?
Yeah, in recurrent setting, if you're planning for if recurrence is within
Yes.
like 2 years of treatment, okay, and it is at the same site, then you can do a FNA to confirm that it is the same tumor. Okay, after 2 years or after radiation induced, their histology might change. So, if you're not planning, see, ideal even in recurrent setting is to do a surgery. Okay, so then core biopsy is much more preferred to know about the grade and all those things. Okay, so FNAC can be attempted only in case of recurrent setting. In upfront, no. Okay. So what is the gauge of the needle you will use for core biopsy?
14 to
Okay.
16 gauge, ma'am.
Okay. So, and can you tell me what all you want to look at in case of a histopathology of a soft tissue sarcoma?
Ma'am, I would like to see which pathology is it. I would like to put further IHC on it. Most importantly, I want to see the grade of the tumor for the
First of
management.
all, like when you take a biopsy, so you want to divide it into how many?
4 parts, ma'am. I want to keep
How many?
one for 4 parts, ma'am.
Okay. Tell what
I-
are all?
Ma'am, I want to keep one for the histopathology, one for the IHC, one for the cytogenetics, one for the molecular.
Okay, fine. So now, pertaining to histopathology, so what all you want to see?
Ma'am, the kind of tumor that we are dealing with.
And one more thing I want to ask: do you do imaging first or a biopsy first?
Imaging first, ma'am.
Okay.
Why? Because, ma'am, doing biopsy might cause post-biopsy inflammation or edema, which might interfere with my findings of the imaging.
So for this also, the exception is very small swellings. Okay, where you are not planning for any imaging. Okay.
Okay.
Fine.
I want to see what is the type of sarcoma that we are dealing with, what is the grade of sarcoma we are dealing with, and
Which grading we use? What are the points in them?
What are the types of grading for soft tissue sarcomas?
ma'am, FNCL-CC grading.
Okay, first thing, what are the types of soft tissue sarcomas means now, as per WHO grading and all,
Ma'am,
what have they considered?
Ma'am, the WHO has divided into 4 types. It is benign, intermediate, which is locally aggressive, intermediate, which might metastasize, and metastatic swellings. And based on the origin of the tumor, the tissue of origin, they have further divided these swellings into benign, intermediate, which are locally aggressive, or intermediate, which might metastasize, and metastatic swellings, ma'am.
Okay. So, can you tell me one example for each?
Ma'am, in cases of tumors which are arising from the there can be areolar tissue that they are arising from. A lipoma may be benign, a liposarcoma may be malignant, and in between there might be benign, locally aggressive, and might metastasize. Right.
Okay. So prior to this, what was the patient based on? Any idea? It was based on
Mitosis.
translocation.
Okay.
So they used to classify it as translocation involving sarcomas.
There are from 2 types of sarcomas. The ones which were found in the young people, they were translocation related sarcomas, and they were usually associated with single chromosomal changes like translocation or deletion or duplication, and these are usually found in the young people. And the other kind of sarcomas had their peak in the 40s, in the 50s, and they were complex sarcomas, and they were seen in 50 to 70 years of age, ma'am.
Okay, can you tell me few examples of translocations? I'll tell you the tumor, you tell me the translocation. Okay? Alveolar soft part sarcoma.
X18 or X13, I don't know.
X17.
17.
Okay. 17 with short term 1125. Okay. Anything this one
Synovial.
liposarcoma?
12-16.
Yeah,
Yeah, isochrome 12 also, na ma'am?
Myxoid liposarcoma will be 12-16. Okay. Then what about Ewing sarcoma?
11-22.
Okay, I'm asking only the important ones. Dermatofibrosarcoma?
17-22, ma'am.
Yeah, 17-22, correct. Clear cell sarcoma?
Clear cell.
12-22.
Yeah. Okay. Then synovial sarcoma?
X18, ma'am.
X18.
Yes. So these are the most important ones. Okay. Other than this, many are there, but they'll not ask in that deep. Okay. So okay, fine. Okay. So what else you'll see?
Ma'am, if there is any need for
What
an
is the origin of soft tissue sarcoma, Savneet?
ma'am, they can be arising from various structures. They can be arising from the adipose tissue, from the nerve sheath, from the vascular sheath, perivascular sheath. They can arise from
Okay.
these can be intestinal cells of Kajal, or they can be smooth muscle.
What is space sarcoma?
Sorry, ma'am.
What are space sarcomas? Space sarcomas. Hello?
That arise between the muscular planes or between the fossa, like inguinal fossa, femoral triangle, the soft tissue.
Yeah, space sarcomas means, see, now you told no blood vessels, nerves or muscles, in which इनके बीच में जो tissue है ना, mesenchymal tissue, so they arise from that space, so they are called space sarcomas. So you tell deep to muscle or superficial to muscle, but some can arise in between also, no, and go to the deeper compartment, so they are called space sarcomas. Okay. So
Ma'am, are the retroperitoneal tumor or the like space sarcoma, ma'am, the arising from the perinephric fat or IVC? That
IVC again, they will be like from the vascular tissue, no? So they are named according to the the tissue of origin.
Okay.
So IVC में क्या होता है? What is the most common?
leiomyoma.
And
angio.
yeah, angio also. Adventitial part also it can occur. Yeah. So any vessel from which layer it arises, it is named after that. So they are not retroperitoneal sarcomas. Like they cannot be called space sarcomas because that retroperitoneum itself is one area, no. So their origin is from retroperitoneum and they go into the peritoneal cavity. Okay, so retroperitoneal sarcomas में क्या है कि compartmental resection का एक वहाँ पे भी है ना, so we remove all the organs whether they are involved or not, involving that compartment in high grade. So that is one concept there. Here also it is there. Okay, here it is divided into compartments. Okay, so that will not be exactly space sarcomas.
Okay.
So, right. So, are there any unclassified sarcomas, Avneet?
Yes, ma'am. WHO has made a list of unclassified sarcomas as well.
Okay, can you tell me few? So, synovial sarcoma?
Yes, ma'am. It is unclassified sarcoma.
What is the origin of synovial sarcoma?
It does not arise from the synovium, ma'am. It arises from...
It's a misnomer. Okay.
Yes, ma'am.
Okay, fine. Epithelioid, ASPTS, all these are unclassified sarcomas. Okay.
Yes.
So, other than that, extraskeletal sarcomas of bone, Ewing's counterpart of soft tissue sarcomas, chondrosarcomas, osteo